Hello and welcome to the Young IFSO session. I think we can start now. Thank you for being here. Unfortunately, we have to competing with the RCT session in parallel, so I think that's maybe the reason why so less people are here. But nevertheless, I think it will be a great session. We have three educational talks and then also three talks that were submitted by abstract for giving young surgeons and scientists the chance to present here in a safe space. I think this will be nice. And the first talk will be by...
Yeah, we're going to invite Karolina Batista Dantis up to talk. She's going to talk about Young IFSO Surgical Dexterity Series, a new competition to create a collaborative virtual academy. She is currently an assistant professor in the Department of Surgery in Natal, Brazil, and she serves as the surgical director for the Brazilian Society of Bariatric and Metabolic Surgery. She's also our Latin American chapter representative to Young IFSO. So thank you, Karolina.
Thank you. Good afternoon, everyone. This is the Young IFSO Surgical Series. Was an idea by our communication committee, Daniel, that had this initiative, but he couldn't come to the Congress, so he asked me to present this project. I have nothing to disclose. So the vision of this project is to build a collaborative effort to do a virtual academy of videos that can be helpful to young surgeons. So we can watch the key steps in a very didactic way of the major bariatric procedures. And the authors of these videos will be Young IFSO members, and these videos will be submitted to the Obesity Surgery Journal as an academic publication, so it will be good to have for our curriculum, but also to build an academy of compiling the best videos in a very organized way. So this is the call for submissions. In the end of the presentation, I will give all the details if you're interested, how you can submit your videos, the criteria, and how you can send to Daniel. The features of these excellent surgical videos, they need to have a comprehensive coverage of the steps of each procedure, so it can be very like a virtual atlas of procedures, very didactic manner. So someone, a resident or a fellow, or someone starting wanting to learn a new procedure, can see your video and replicate this procedure in his hospital. So the content should be accurate and reflect the latest surgical techniques. The video can integrate schematics or position of the patient to be the most clear it can be. We need to narrate the videos as the obesity surgery usually requires, and should be presented in an informative manner to add some knowledge to the audience. And why videos? Because videos is video-based learning is very important nowadays. We have all the time our cell phones, and we are learning from videos every day. So the scientific publication doesn't need to be restricted to articles, and we can publish on videos and learn from videos. And the challenge of this video academy is not to create short content just to, I published at the journal, but to be useful and create something that we can see in the OR with our residents or our medical students while we're waiting for a surgery. We can have handheld content to share knowledge. Nowadays, YouTube is the most popular site, but there are other platforms like WebSurge that has, or the AES channel that have great content on video. But to have this virtual academy, we could have something from IFSO Society specific to bariatric surgery that could be curated in a more academic way. There are several scoring platforms for the videos, and we will use one of these to evaluate the video submitted to this program. And the ultimate goal is to use this virtual academy to improve our practice, to share knowledge, and become a better surgeon with a more accurate technique. There are some other initiatives from SAGES, especially. SAGES has a lot of content on video and on their YouTube channel, on their website. As I mentioned earlier, the web search platform has 20 years of content. The IES channel has a lot of interesting things also, but they mostly have classes, not only surgical videos. There are already Young IFSO members publishing in obesity surgery. There is a specific session with multimedia article. You can publish even a systematic review with a multimedia article in the new platform, but you can publish case reports or case series as brief communication with the video attached to the manuscript. And this is a recent publication by Young IFSO members. The Young IFSO mission is to support excellence in education in bariatric surgery, and our friends here are sharing a lot of knowledge across other countries in the world and doing continuous education events for younger surgeons. So how to submit your video? This is the current criteria from July to December this year. The subject is surgical management of early complications after bypass. You have to be a Young IFSO member. Your video has to go from 7 to 12 minutes. You have to send it by email to this Young IFSO email. You have to upload your video already edited and narrated in English to a WeTransfer or some other Drive platform, and also a title page in the format of the obesity surgery title page. And this will be peer-reviewed by at least 2 reviewers using that usefulness score of video publications, and an answer will be sent back to you if your video will apply for the obesity surgery publication. Thank you.
Very much, Karolina. This is great. I think 6 videos have been submitted until now, and the best one will be published in obesity surgery, right?
Yes.
And the best ones will be published in obesity surgery? Yes, we have an agreement with them. Any questions? So we can go to the next speaker, Helena Huis from Spain. She is also secretary of Young IFSO and a long-lasting friend. And she will speak about availability of robotic MBS for young surgeons.
Good afternoon, everyone. These are, all my disclosures that I don't have any. It's here. Yeah, so, let's see. Okay. So, I'm John, but not so John. You see that I have to use my glasses. Oh my God! But if we start talking with when I start my review on prepared to this talk, actually I didn't find many data of surveys or of what metabolic and bariatric surgeons think or the idea about training in robotic surgery. But we know that metabolic robotic surgery is increasingly available for young surgeons, although access depends on institutional investment in training programs. while it is growing in bariatric surgery, driven by benefits like improved ergonomics and potentially faster patient recovery. So, but what factors are influencing in the availability for gen surgeons? Of course, training programs, structured programs that are being developed and implemented to provide residents with fundamental robotic skills during their training, institutional adoption, that's robotic systems and integration of the robotic surgery into the routine practice is key. Specialty focus and also the cost and economics is also a very important factor to adopt robotic surgery. Oh shit, sorry. So we have a look at some papers about what our gen surgeons seeking for, or what they think about training in robotic surgery. We know, for example, in these papers that we have a look to United Kingdom and Ireland. Look at this data. Almost all the 75% of trainees get value greater access to robotic surgery training, believe that robotic surgery was important for the future of their desired specialty, and believe it should be incorporated into formal surgical training. So they perceive also the disadvantages of robotic surgery experience in surgical training as expense and the current impact of consultant robotic learning curves on training. And this other paper comparing or talking about United States, comparing with UK and Ireland, this is very nice because we can see in these graphs that, look, there are huge differences between UK, Ireland, and States, United States. We can see that, for example, in these graphs, that mainly in United States, surgical trainees have had significantly more exposure to training in robotic surgery than in UK and Irish counterparts. So that means that in Europe, we have less access than in US, and this is very important to highlight. Or what about, for example, this is a survey, Delphi consensus study with different specialties, and in all of them, in UK surgical trainees on the adoption of essential components of procedural robotic training, they take 85 surgical trainees representing the spectrum of all the specialties, and its trainees strongly supported the integration of robotic training into surgical curriculum, and therefore there is a robust consensus amongst UK surgical trainees with this in this idea. So the learning of the robotic approach, we need a phased introduction, of course, a team-based learning, and ergonomics and workload. So what robotic programs do we have available to make easier to reach our goals on training robotic programs? Okay, we can have a look to the course curriculum. Course curriculum, more than a program, is a score. It's a score and scale and score that measure critical component of the training program. It's an objectively measuring a surgeon's proficiency in robotic techniques. Course scale does objective assessment, skill differentiation, and competency-based evaluation. And the key components of the course assessment are a standardized scale, video review, and reliable scoring, and how CAR is used in robotic surgery training with integrated ed into training programs, tracking progress, and identifying skill gaps. So for example, in this paper, they show how you can use the course scale and how the scale and the score of cars improved as the way that you raise in your level of from beginners, intermediate until advanced surgical trainees. And we can also have all the programs and tools, like, for example, the robotic curriculum for young surgeons, that it was implemented in the daily routine of a German university hospital started in 2020. And ROCKS is a multimodal training program, basic training for assistant at the operation table during robotic-assisted operations, and also basic consult training. So ROCKS is a strong training tool to meet the specific needs of young surgeons and evaluate their learning success of robotic procedural training. And furthermore, comparison within the different robotic systems should be considered. This the graphics of how it works with the different levels. And here is another paper about if ROCKS entails any difference in the results on the safety in our patients, in the outcomes of our patients. And we can see that it's safely and can be safely integrated into clinical practice without compromising the patient safety or the oncologic quality. What else? I mean, for example, in America, they have this program, the START program. It comes from the ASMBS, and it's a program but just for use as fellowships. And look at this data, maximum 45 fellows, so it's very, very, very few fellows. And the program will train bariatric focused fellows who are currently in a fellowship council approved fellowship program, but just from United States. Or the RAS program, this is another program based on 3 different modules. The first one is for ergonomics, the second psychomotor, and the third procedural. And this is a paper who evaluates and assesses the module 1. And with this module 1, the responsiveness of the general surgery residents with 54% talking time reduction and no differences in hands-on testing scores. And for example, we have also, this is a program or a tool that created by the Dr. Mario Rui Gonçalves from Portugal, and is a type of silicon models that they can be used in different courses, very, very useful. We from Young IFSO, we have the experience using this kind of silicon models, and we can see and they publish the data of how happy or how much adequacy the residents find in using this kind of silicon models, and they find it very, very useful to develop the robotic skills. In fact, you see here the silicon models. They were used in, for example, 2024 in 2 courses, very interesting courses. One of them in Frankfurt, in the Frankfurt meeting, during the Frankfurt meeting, and the other one in Detmold, in November 2024, with our esteemed colleague that is here, the Dr. Miljana Vladimirov is over there. So, and we find them very useful to acquire that kind of skills. Look at the data, 65%, almost the combination of formal lectures with hands-on lab experience. Trainees want a mix of both. And in terms of training course, 76% prefer robotic surgical course be organized independent of a conference. And the trainees wanted include, all the courses include a hands-on exam. They will lead to a robotic surgical certification. They are looking for certification, official certification, and the robotic surgical courses should contribute to develop a robotic surgical teaching curriculum. I want also to present, for example, the intercontinental training program from TROX. Is an association of robotic surgeons. And I want to show you that you can use it and you have the opportunity to apply for this kind of programs, available programs in Texas, in Mexico, in worldwide, in France, in Luxembourg. Once again, my esteemed friend, Dr. Miljana Vladirinov in Detmold, Germany, in Osaka City with Dr. Seiki Kitayama that is also here, and in Colombia or Ecuador with Drs. Adolfo Perez Bonet or Omar Rivera. Sorry. There are also other programs that we are not so familiar with them, but for example, Fundamental of Robotic Surgery from Florida and Orlando groups. There are two different groups. The Fundamental Skills of Robotic Surgery that is from Buffalo, the BSTC that is from Toronto, or the proficiency-based robotic curriculum is from Texas. Those all are from multi-specialties. They are not focused in bariatric surgery, but they can be very useful because nowadays, except VA as BS, we don't have a model or a program-based just in bariatric surgery, but we have to work on it. So the future of robotic metabolic surgery means that we have to a growing momentum, which is based on innovation and advancement. And I think that the requirement of boosting and spreading robotic educational programs worldwide is key. We have to think that the first idea is the patient safety, and we have many challenges specific for robotic surgical training. So my conclusions in a glance, I like so much this slide because I think that the trainee views on one word is very, very visual, this slide. If we ask trainees about robotic surgery, they think in future, in expensive, in innovation as well. But if the first word, for example, that think when they hear robotic surgery is something about future, about innovation, and the first advantage for trainees are that robotic means precision, ergonomics, and of course, always is the same, that the first word of disadvantages is expensive, cost, and that the training programs nowadays is a little bit hard to reach, but I think that we have many tools and many programs. But I think that the first thing is that all of them, if you realize, is that all of them are in United States or Europe, but not worldwide. So from Young IFSO, we have to work on that, on spreading and launch a lot of programs, but worldwide. And we need also to know what our young bariatric surgeons trainees need and think. That is why from Young IFSO we have just started to develop a study, a survey, to ask all of you, young bariatric surgeons, your opinion and about training in robotic bariatric surgery. And we are delighted to wait for all your answers, and we are just working on that. So in the next few months, you are going to see the results of that survey, of that study. So that is for all, and thank you so much for being here.
Thank you so much. That's a great talk, a great plug for our study that we're going to be doing soon too. So thank you again for that. And we're going to invite Karolina back up. She's going to talk about scientific start for young surgeons, reading, reviewing, and publishing papers.
So I'm back again, and now this is my official talk. We think this is an important topic to talk here in the Young IFSO session, how to have a scientific start for young surgeons, how to read important things in bariatric surgery, how to start publishing, and how to start reviewing in bariatric surgery. I have nothing to disclose. So why scientific skills are important for a surgeon if you're not in the academic job, if you're working and doing surgery in your patients? Metabolic and bariatric surgery now is science-driven. You've seen in the other talks yesterday and during the morning. We have data, we have trials, and now with the GLP-1 medications, we have to provide significant clinical data to show for these results that bariatric surgery also have strong data, strong results. The scientific skills can improve our patient care because we are more informed and doing an evidence-based medicine to provide the better care for our patients. And also it can exercise our critical thinking, especially nowadays with AI. We're not exposed to think that much. We just ask ChatGPT and it gives us an answer, a review, and we have to do this continuous effort to think critically. So how can we move forward from being just consumers of knowledge to being contributors? So I think this is the main thing about this talk. About reading, all of you, of course, have read many manuscripts along your journey, your academic journey during training, but we have to, every day there is a large amount of new publications. How can we know what's important? How can we improve our time reading and getting the best information? So we have to do this continuously to compare our own results to the bigger scenario of the best evidence. If you want to improve your reading and do it more in a smart way, you can start with reading the abstract and searching for more significant publications. You can use the PICO framework that has the population, the intervention, the comparison, and the outcome. This is especially good for trials. Of course, we can use AI. I'm not going to be judgmental here. I use AI a lot, but not to ask like, please give me a review about this manuscript or give me 5 topics about this manuscript. I use AI to talk like I'm talking, discussing with a peer. Like I try to do like a journal club with my ChatGPT. So I provide the PDF and then starting asking questions to critically analyze this manuscript. And it does a really good job. I don't know if any of you has tried that, but try to talk to your AI, not only ask for 5 topics or 1 slide on this manuscript. You can actually have good conversations, especially analyzing statistics or the methods of this manuscript. One important question, especially for younger surgeons, residents, fellows who are starting to get contact with bariatric surgery, is how can I find these relevant publications? So a first suggestion is go to the journal's websites, especially obesity surgery, that is IFSO's journal, and SOAR, that is ASMBS journal. Every month, every edition, you can search on the website, but you can also put your email to receive a newsletter every month with the new publications. I think that's a start. And also in the bigger, more famous journals like JAMA, New England, Obesity, every month there's something new in obesity or in bariatric surgery. For example, this past month in August, there was a very significant publication in the British Journal and also a very important trial in Lancet. So I always go through that bigger journals searching for relevant publications. Also, you can follow journals and surgeons and societies on Twitter, Instagram, social media. You can create a journal club in your university with your friends, your surgical team, or you can have a lot of pictures from the Congress and search for these manuscripts later on at home. And how about publishing? Where to start? I think we can start, I always say we can start small, especially if you are resident, a fellow or junior surgeon. We can start with case reports, case series, video cases like this session we want to do with the Obesity Surgery Journal. You can show the specific data you have in your hospital. You don't have to do big randomized trials. You can start with small publications. But again, how can I do it? So I think the primary thing is to find a mentor. It doesn't necessarily has to be a scholarly teacher. It can be your senior resident. It can be sometimes your chief resident or some friend of you who is already more experienced, and you're going to do something together. You can focus again in your local experience. You can search for partnership in other research groups, in other hospitals, here with us at the Young IFSO or at your local society of bariatric surgery. And you can do a lot of networking online in your own society and also at conferences like this. I think it's a great opportunity to search for research partners and research opportunities. How to start writing? Of course, I will not explain a lot in such small talk about this very complex and difficult situation that is scientific writing. But I think I can give you some advice of my own experience. I think we should start with simple, clear English. If you're not a native English speaker as myself, you can try to write in your own language and then translate. But I find it very difficult, especially for us that have Latin languages. Portuguese, Spanish, Italian, French. We have very long sentences, and in English and in scientific publication, we need short sentences. So I find it more easy to write in English and then review with a translator, or now I review with AI. Again, about AI, use it to review, not to write. As reviewers for the Obesity Surgery Journal, when we receive a paper written with AI, it is obvious. We know it was not written by a person. It has very specific things that show us it was done with AI. Also, you will never learn to write if you're always using AI. Choose the right journal, so focus on obesity and bariatric surgery journals. You have to fight against perfectionism. We always want to do the best manuscript in the world. Sometimes send it to the journal. You have a great peer review that can help and improve your manuscript. And it's very difficult to have the paper rejected, but we also must learn to improve our manuscript with the rejection and the reviews. I usually have a lot of attention with the reviews I receive from the manuscripts because they're very good to improve our writing. And after you start to publish your own manuscripts, you get invitations from the journals to become a reviewer. Even as young surgeons, it's a great opportunity for us. We can contribute a lot. You don't have to be a full professor, senior researcher to do a peer review. And it's a great opportunity to improve our ability to write, improve our critical thinking, and also builds academic visibility. I was just now in the obesity surgery editors meeting, so it's a great opportunity to meet senior important professors for us. The steps of a good review: when you start to review your manuscripts, be constructive, help, put yourself in the place of that person who is submitting the article, be constructive, give advice on how to improve the manuscript, focus on originality, clarity of what is written, the ethics of the manuscript, if it's a trial or a perspective in a new technique, if it had confidentiality, if it shows the conflict of interest of the authors. And also be very attentive to improvements regarding tables and figures. Sometimes we get a lot of, especially in manuscript from other languages, we get lost on translation. How to start to review as a young surgeon. You can co-review with your mentors or your professors. You can volunteer on the journal websites. Some Elsevier, Springer, they have opportunities, so you can add your name, your email to become a reviewer for a specific journal in a subject you're interested. Start on smaller journals. There's a lot of journals on PubMed and Medline that are based on case reports or video case reports. You can start with that before going to bigger journals. And when you publish your manuscript, you usually get invitation from that journal. So if you publish in your obesity surgery, after a few months, you start to get invitations to be a reviewer. And the more you review, the more invitations you get, and you learn a lot from that. Also, some societies and some journals, like the JAMA Surgery, the British Journal, they have Reviewer Academy. There is specific training for new reviewers. That's very interesting. So to finish our talk, I think this is a long journey for us. We have to start early. We have to focus a lot on this. But if I could give some advice, start small. We start with videos, with case series. Find good mentors that will help you. Stay consistent and aim high to publish the best scientific knowledge we have. Thank you.
Thank you very much, Anna Karolina. Just a few questions that maybe I have. I'm sure you can answer that. Not every hospital has the possibility to download all the papers. So how can they reach all these papers?
Some societies like IFSO, if you're IFSO member, you can go on the website and log in as IFSO member, and then you click on Obesity Surgery Journal and you go to the journal. That's a way. Some websites like Elsevier or Springer, if you, especially Elsevier, if you're a reviewer or your society has a partnership, you can go on the website and log in to get this information, the access to the manuscript. You can talk to the author on Twitter or by email. Usually when we publish, the journal gives us a link with the ReadCube, a link to access the full manuscript. We cannot download, but we can read, and we can share that on social media. No rights, it's nothing against the law. And you can ask your friends on WhatsApp groups to download in their university and send you. That's an option. I believe that are options.
I was very happy that you really give this very practical talk, and I think this can really help. One more question is, more and more we have also some kind of international writing group. What do you think is better to start? Should you join some of these international writing groups, like also Young IFSO has one? Or should you stay with the first articles in your hospital, with your mentor, with your safe space? What do you think?
I've experienced both situations. I think when you join an international writing group, you have to have some experience in writing. Sometimes when you start in your own hospital with a small group, with like video case or case report, you can start small, go in your own pace and rhythm, because sometimes the international group, they're a very strict agenda, and you have to deliver your part of the job that you don't know how to write in English, you don't know how to do the tables and the statistics. So I think the international group is for like the next step. I would start small in your own hospital.
Thank you very much. Actually, you have to sit down with us here because you're also moderator, right? And we can go on. So this was the first part of the session. In the second part of the session, we have the best abstracts that are submitted with the category of Young IFSO. And the first speaker is from Australia, Rosalind Wii. Comparing the effect of metabolic bariatric surgery with very low energy diet on preference for highly palatable food.
Thank you. My name is Rosalind. I'm one of the general surgery registrars at St Vincent's Hospital in Melbourne, Australia. And today I'm honoured to be able to present some of the research I've been working on as part of my PhD with the University of Melbourne, looking into potential gut-brain mechanisms to explain food preference changes after metabolic bariatric surgery. I have no conflicts of interest to declare. Currently, more than 2 billion people are living with obesity globally. And this is an issue due to the many complications associated with obesity, such as cardiovascular disease and type 2 diabetes. But many of these complications can be prevented or mitigated with as little as 5% weight loss. Long-term maintenance of this weight loss, however, is required to sustain those health benefits. And this is challenging for most people due to the complex interplay of behaviour, biology, and the obesogenic environment. Our bodies are wired to find high-calorie foods, those rich in sugars and fats, the most palatable. And this reinforces their intake and can drive our overconsumption of these nutrients, leading to weight gain. Metabolic bariatric surgery remains the most effective and durable treatment for obesity. As well as profound weight loss and metabolic improvements, patients report a reduced preference for sweet and fatty foods. How bariatric surgery results in this change in food preference is currently unknown. And it's also unclear whether these changes are intrinsic to the surgery itself, resulting from anatomical rearrangement induced by the surgery, or whether they occur secondarily, either due to weight loss or conditioned dietary avoidance following perioperative nutritional counselling, or responsibility to meet clinician expectations. Direct comparison with the effect of non-surgical interventions on food preference, such as the very low energy diet, may help untangle these potential mechanisms or drivers. As such, the primary aim of this study was to compare the effect of metabolic bariatric surgery and very low energy diet on preference for sweet and fatty foods. Secondarily, we aim to investigate any association between changes in food preference after each of these interventions with weight loss. To address these aims, we conducted an observational pre-post study in patients, adult patients, waitlisted to receive either primary sleeve gastrectomy or Roux-en-Y gastric bypass at one public centre in Melbourne. Patients taking medications for weight loss or for diabetes were excluded from the study due to the potential confounding effects of these medications on eating behaviour. And we measured preference for palatable foods using previously validated questionnaires, the Sweet Taste Questionnaire and Fat Preference Questionnaire. Anthropometric, laboratory, and food preference questionnaire data was collected at baseline following a very low energy diet and 12 months post-surgery. The very low energy diet consisted of OptiFast meal replacement products 3 times a day, with non-starchy vegetables and a tablespoon of oil. And all of this totaled less than 800 kilocalories per day. The duration of the prescribed diet was between 2 and 9 weeks, and this was at each treating surgeon's discretion, largely based on that patient's baseline BMI and the surgery to be performed. Our data collection is still ongoing. Currently, we have 22 participants recruited to the study, 17 of which have completed the very low energy diet and received their surgery, and 10 of which have completed their 12-month post-surgical follow-up. So the data that I present today is for those 10 patients that have completed the study. This consisted of 2 sleeve gastrectomy patients and 8 Roux-en-Y gastric bypass patients, and I've combined them into one post-surgical group for the sake of today's presentation. At baseline, 60% of the 10 participants identified as female with a median weight of 146 kilograms or a BMI of 52.5. We found that both very low energy diet and metabolic bariatric surgery were associated with meaningful reductions in weight and BMI, as well as improvements in markers of glycemia and lipidemia, confirming their efficacy as weight loss interventions in our cohort. While very low energy diet was associated with reduced frequency of consumption of high-fat food, which is consistent with dietary adherence, preference for the taste of these high-fat foods remained high post-intervention. Whereas 12 months following bariatric surgery, participants not only recorded a further reduction in the frequency of their consumption of high-fat foods, but also reduced preference for the taste of these high-fat foods by at least 30%. In terms of sweet preference, we saw a numerical reduction in questionnaire scores after surgery, but not very low energy diet. And this was in particular relation to patients reporting their controlling their eating of sweets. But these have not met statistical significance with the current sample size. While there was a median total weight loss of 4.5% after very low energy diet and 28.5% after surgery, weight loss after neither intervention was associated with any change in food preference scores. So what does this mean? Well, overall, we found that both metabolic bariatric surgery and very low energy diet are effective methods of weight loss with associated metabolic benefits, but only surgery reduced preference for high-fat foods. This suggests that post-surgical changes in food preference are specific to the surgery itself and not dependent on any conscious dietary restraint. Furthermore, this change in food preference was unrelated to the magnitude of weight lost. This may be because the mechanisms underlying post-surgical changes in food preference and those underlying weight loss are distinct. But this is not to say that post-surgical changes in food preference are not clinically important. It may just mean that they play more of a role in long-term weight loss maintenance instead. This brings me to the future directions for our study. Firstly, to continue data collection into the weight loss maintenance phase by tracking preference for sweet and fatty foods at the 3-year or 5-year mark. We'll be able to better understand the relationship between eating behaviour and long-term weight maintenance, which is a currently understudied area. Secondly, we plan to investigate potential mechanisms stemming from the gut that is associated with this change in food preference. And we've actually harvested gastric, duodenal and jejunal mucosal biopsies via gastroscopy at each of the 3 time points in the study. We're going to use these biopsies for spatial transcriptomic analysis to map genetic changes that may be associated with the change in food preference we've seen. And this will have a particular focus on post-ingestive nutrient sensing. We hope that understanding the mechanisms associated with the reduced preference for highly palatable foods post-surgery will not only optimize outcomes for future patients, but it may provide the opportunity to replicate this effect via non-surgical weight loss methods. Thank you.
Thank you for that great presentation. That's very interesting stuff that you guys are doing. I do have one quick question for you. It's very interesting to me that even though you guys had a higher cohort of Roux-en-Y gastric bypass patients, they didn't really find that they had a less of a preference for sugary foods, which I feel like we would expect them to, given the risk of dumping syndrome. So do you know, were you able to evaluate if any of those patients had experienced dumping in that first year?
We didn't look for dumping syndrome specifically in this cohort. With the numbers that we have, we've tailored the power and sample size based on the number needed to see a change in the biopsies, which we haven't quite gotten to yet. And so the significance of the sweet preference scores actually flicked back and forth between significant and not significant when we have added more patients that have completed the study. So originally when we were at 8 or 9 patients, it was significant. And unfortunately for today, it wasn't. So, yeah.
Good work. I'm looking forward to hearing more about this in the future, some of your further follow-ups. It'll be interesting.
Thank you.
Yeah, also very interesting talk, and I have also one more question. Have you also considered to do this study, for example, with GLP-1 as another arm?
Yes, unfortunately this is a public centre and there aren't that many patients that we have that were on GLP-1 agonists just because of the cost and the access at Melbourne, Australia at this time. And this was observational study. So ideally, yes, we would do a randomised control trial and be able to look at the differences between them. We are actually also in the process of applying the same food questionnaire to patients undergoing endoscopic mucosal resurfacing because we want to look at if the duodenal exclusion there has the same effect as bariatric surgery. So that's something that's currently underway.
I would like to add a comment also. Congratulations, very interesting, very useful in our clinical practice. Patients report that a lot. Just when you finish your research and you are going to publish, if your primary outcome is the food preference, you should report that first, not the weight loss. First your primary outcome, and then your secondary outcome. It's more, it's a reporting aspect, but it's more interesting also for us who are reading. Mm-hmm. If your study is focused on this, it should be reported first. Thank you.
All right, thank you again. We're going to invite up Matthias Sosa from Argentina to present his abstract, Paragastric Neural Block, an emerging tool for pain and nausea management after sleeve gastrectomy.
Hello, everyone. I apologize for my voice. It's been a rough days here in Santiago. Thank you, Marit, for the invitation. Well, as the title says, I'm Matthias Sosa from Argentina, and here is our experience in paragastric block. It's a study we carried out with another colleagues and friends. And basically, we started with the question that if can sleeve gastrectomy, its postoperative, can be improved to shorten hospital stays in bariatric surgery, because we are a center that focuses on ambulatory bariatric surgery. As a background, this is not new, the ambulatory bariatric surgery. There are some reports for more than 20 years, but mainly in gastric bypass. And we are a group of centers that focuses on ambulatory bariatric surgery, as I said before, is one of our main goals. So when we have somatic pain, we can use the TAP block, but when it comes to visceral pain, it could be more difficult. And due to that, in sleeve gastrectomy, it performs like a high-pressure system due to the pylorus. So it could be related to prolonged length of stay and readmissions. So this work came out recently from a group of Colombian bariatric surgeons and anesthesiologists, and it's called Paragastric Autonomic Neural Blockade, and it could be used for both nausea, vomiting, and visceral pain. It consists on 5 to 6 installation of bupivacaine, and one more when you mobilize the dissected stomach. So what was the objective of our study? To assess and compare the effectivity of this block as a treatment for pain and nausea, vomiting in sleeve gastrectomy. That was our Achilles because gastric bypass has a much better postoperative. and to evaluate its potential benefit in our main focus and main objective, that is ambulatory bariatric surgery. So how we did it? As I said before, we are two centers, one I have with Pablo, my colleague and partner, in Santa Fe and Argentina cities, and then the other group of friends that is supporting here right now, Carlos, Manu, in Córdoba, my bariatric alma mater. We divided into two groups, a total of 300 patients, one with the neural block and another control. All of them underwent this protocol of opioid-sparing anesthesia multimodal approach. And to the first group, we added the paragastric neural block. For those who do not know, the inclusion criteria was primary bariatric surgery, a BMI between 35 and 50, no comorbidities at all, and a preoperative anesthesia interview 7 days prior. And we evaluated pain, nausea and vomiting at 6 hours postoperative and at the moment of the discharge. Well, basically this is the technique we perform. The installation of in 5 to 6 areas in the lesser curvature. And we basically use 20 cc of bupivacaine. We need to be very careful because sometimes we can cause an hematoma that when it happens, it could be all the benefit of the blockade could be lost. Well, what did we get? Well, basically of all the patients that we recruited, around 80% were women in both groups, in both centers, sorry. And according to pain management, we divided them in the 6 hours and moment of discharge, around 24 hours, with a very significant difference between the lesser pain in the block group, and then in group to mild to moderate to severe in the control group. And what about nausea and vomiting? Mainly the same. We had like much more benefits in the control group, in the block group than in the control. So to sum up, this paragastric block is safe and effective. The operative time we spent in performing the blockade is around 4 to 5 minutes. It's not that much. And it reduces pain, nausea and vomiting, and the analgesia requirements. And this might help us to become part of this multimodal approach that we perform to reduce pain, nausea and vomiting, and as well as the hospital stay and its cost. This is us with our patient, with Pablo's, and we are very proud to show our results, our experience. Thank you.
Thank you very much. Any questions? Maybe I missed that. Do you do this on primary sleeves or on revisional?
Yes. Exclusion criteria was revisional surgery or conversion surgery.
Okay. Is this something that you would also consider? For example, sometimes gastric bypass patients have some pain in the left lower abdomen.
Carlos and his center are recruiting patients for gastric bypass, but mainly this study, we started it because we noticed a very huge difference between the postoperative symptoms of gastric bypass and sleeve gastrectomy. That was the main reason to start just in sleeve. And now we are opening the recruiting criteria to gastric bypass to perform maybe another study or looking for some other outcomes and to see if there's any difference between gastric bypass and sleeve gastrectomy.
So is this something that you would now do for all sleeve gastrectomy patients,
Yeah.
or just on some patients
Now,
selected?
now that we have finished this study, in every patient we perform this. And this technique let us elevate or rise the percentage of patients that could achieve our protocol of ambulatory bariatric surgery at around 50%. 50% of our patients lives in the same day.
Great, thank you.
Thank you.
So for the next presentation, it's Pattarasai Kachorviataya in the outcomes of conversion metabolic bariatric surgery after fundoplication, comparative analysis of sleeve gastrectomy versus gastric bypass in 499 patients. Did I spell your name almost correctly?
Yes, no one can spell my name correctly at the first time. You'll be one of them, yeah. Thank you, IFSO and Young IFSO, who give me great opportunity to share my research. I'm Dr. Pattarasai from King Chulalongkorn Memorial Hospital, Bangkok, Thailand. But now I'm a research scholar at Cleveland Clinic, USA. That's where you can good start for the research in your early career. And I would say I'm real young because I'm in the early career of my bariatric surgery. Yeah. Okay, so my topic will be room-wide gastric bypass and sleeve gastrectomy, list adjust safety profiles after previous fundoplication. It's 499 patients for the analysis of MBS equipped database. I have nothing to disclose. So we know that obesity and GERD are frequently coexist, and fundoplication is effective, but failure rate is up to 30% in patients with obesity. So what we have, the next options, it could be redo fundoplication, or do we have to convert to the bariatric surgery? That is depend on your indication, the cause of the failure. But the evidence gap is that there's a limit data on the safety outcomes of sleeve gastrectomy versus a room-wide gastric bypass after your failed prior fundoplication. The objectives of the research is that to compare 30-day overall serious complication rates between sleeve gastrectomy and room-wide gastric bypass. And we need to identify the predictors of adverse outcomes. So the studies we do the retrospective cohort analysis from the MBS AQP database between 2022 to 2023. Our population is adults undergoing primary bariatric surgery, which is sleeve gastrectomy and room-wide gastric bypass, with a history of fundoplication, and we exclude all emergency surgery or conversion surgery or prior bariatric surgery. We collect demographic data, operative details, and also the outcome is 30-day complications. And we use a univariate and multivariate logistic regression for the analysis. Our patient cohort, the mean BMI is higher in the sleeve gastrectomy group, about 42.4 versus 40, than in a room-wide gastric bypass group. And the GERD prevalence, interestingly, is reflect the real situation of our practice, that it is higher in room-wide gastric bypass group of 73% versus 47%. But for the other comorbidities, no significant difference between two groups. The total 499 patients included in 373 patients, about 45% for the room-wide gastric bypass, and the rest is sleeve gastrectomy. When we look at the indications, we found that the majority of patients is weight gain, about 43%, followed by the GERD issue, about 32%. And the rest is persistent associated medical problems or other indications. So for perioperative outcomes, in this group, we found that they have concomitant paraesophageal hernia repair. Majority is in the room-wide gastric bypass group, about 45% versus 26%, which is higher in room-wide gastric bypass group. And for the operative time is higher in the lung gastric bypass group, as we know that is mostly higher than a sleep gastrectomy group. And for the length of stay, also the same. That is higher, is longer in a lung gastric bypass group when compared to the sleep gastrectomy group. When we look at the healthcare utilization between this group, the 30-day outcome of the readmission is higher in the lung gastric bypass group, compared 11% to 3.2%. And also the reoperation rate is higher in the lung gastric bypass group, 4% versus 0. But there's no significant difference in the non-operative intervention between these two groups. To look at the 30-day complications, for the surgical complication, all the variables, leaks, post-operative bleeding, bowel obstruction, or surgical site infection, or wound disruption, and also the sepsis. It's not significant difference between gastrectomy group and a lung gastric bypass group. Also, for the medical complications such as cardiac events, pneumonia, unplanned intubation, VTE, and acute kidney injury, there's no significant difference between two groups when we perform the univariate analysis. But for the overall serious complications between sleep gastrectomy and lung gastric bypass, we found slightly different of 9.6% in the bypass and 4% in the sleep gastrectomy group. For the mortality, there's no difference between two groups. 0 in sleep gastrectomy and 2 patients in a lung gastric bypass group. For when we use the multivariate logistic regression, there is no significant serious predictor for the serious complication, including also the concomitant paraesophageal hernia repair in both groups, and also the higher BMI, older age, sex, race, also the comorbidities. Even in conversion to lung gastric bypass compared to sleep gastrectomy, there's no significant difference for the serious complication predictors. So I think that the procedure type not independent predictor for the serious complication, and even though you perform the concomitant paraesophageal hernia simultaneously, and there's no other factor that are significant predictors. Our limitation is the case document after 2022 is the first time that fundoplication can access in the MBS ACUP database. And also the only 30-day outcome available. Also the severity of GERD symptom not captured. And the main thing is the type of prior fundoplication, takedown status, surgical technique, and also the surgeon experience is unavailable. And also is quite different in the incisional protocols, and the decision making is not standardized. In conclusion, I think both of sleep gastrectomy and lung gastric bypass are the viable options after prior fundoplication. It depends on the indication of your patient, which was weight gain or GERD issue. For unadjusted, the higher serious complication found in the lung gastric bypass group, but after adjust all parameters, there's no difference. So I think the patient selection is the key to select the procedure. But I would summarize as lung gastric bypass still remains the favored option for patients with obesity and the persistent GERD. Thank you.
Congratulations. This is a very interesting publication. I think we'll get more of these patients in the future. But it's the limitation whenever we have a database information is that we don't know the clinical reasons that the patients receive different procedures. Usually in our practice, if we're doing a surgery for GERD, bypass patients have more severe GERD, usually higher BMI, or greater complication from the previous fundoplication. So it was expected in a kind of way that those patients would have more complication and longer surgical time, right?
Yes, I agree. Yeah.
But anyway, this is very interesting. just when you submit this to publication, I wouldn't put in the conclusion that bypass is still the best procedure for reflux, because this was not analyzed in your study. You focused on the complications, not the outcomes of GERD. You can use this in discussion. I agree, bypass is the best procedure for reflux, but your data doesn't show this, so I would take it from the conclusion.
Yes, I agree. Thank you.
One more question, not about the study, because the Young IFSO session, it's also very interesting about career and things like that. So you're, on the first slide, you said you're from Thailand, but you're now at the Cleveland Clinic. Do you do a fellowship there, or how is your career pathway?
Okay. I finished my Bariatric fellowship in Thailand, yes, but now I'm a research scholar at Cleveland Clinic. Yeah.
Thank you very much.
Thank you.
So the last talk we have is from Sihan Sahan, and he's from Turkey and is also living in Austria, and he will speak about modern bariatric surgical education, the Virtual Academy.
Hello everyone, good afternoon, dear chair. First of all, I would like to thank Camilo and the IFSO organization team for giving me this opportunity. Modern bariatric surgical education, the Virtual Academy. Why change is needed all the world? Obesity is a global epidemic, yet training opportunities vary greatly. Traditional training is valuable but not scalable or equally accessibility. Need for global, standardized and affordable education models. As you can see on the map, the current obesity rate in the world is very high, and the predicted obesity rate in 10 years is much higher. With the increase in obesity rates, many new techniques that have an impact on the metabolic field are emerging, such as magnetic surgery. The concept of the Virtual Academy, access to expert video and tutorial, live or recorded case discussions, simulation tools and VR-based skill development, mentorship and peer-to-peer feedback worldwide, interactive ecosystem for surgical education. Benefits of the Virtual Academy: standardization, reduced variability in training, accessibility supports surgeons worldwide, flexibility, on-demand learning anytime, networking builds a global professional community. Personal experience, sharing annotated surgical videos with global colleagues, details of the techniques used in obesity surgery, encouraged global dialogue on techniques and best practices. Here I will show you different revision surgeries on 2 patients who had previously undergone Nissen surgery. Sometimes we need to make decisions before surgery or sometimes during the surgery. There is no single treatment method for every patient. In this video, the patient has 2 years ago Nissen fund application, and the hiatus completely open, and the rep was detached. And I decided to make for this patient to repair the hernia and convert to bypass surgery. Currently, the bypass classic, I started to make this biliary limb longer than standard bypass. 150 biliary limb and 75 alimentary limb, as Mufi described it on IFSO site. Therefore, we have a lot to learn from the virtual academy and other surgeons to decide what to do. We need a new platform to discuss selected cases. We can create a web platform under the IFSO to which every member can contribute, such as web search or SAGES. And I want to show you other video. This is another case. Underwent Nissan, and this patient has no GERD symptoms. And we just decided to make the sleeve gastrectomy without touching rep. And you can see here, we want to see first, and after that, we leave it like that. Looking into the future, surgeons across continents joining the same virtual OR, watching complex revisional cases in a real time, interactive collaborative learning without borders, and virtual reality and AI will feature enhance surgical training. Video is done now. We always closing this stapler line with the serosal closing and the omentopexy. Last 3 years, there is no problem. We'll finish now. Robotic bariatric surgery and remote operations, also in the future we can consider about it. Robotic systems are increasingly used in bariatric procedures. Enhanced precision, ergonomics, and visualization, potential for telesurgery, performing operations remotely. Feature combining robotics with virtual academy for live training. To conclude, virtual academy complements traditional mentorship, promotes continuous, borderless learning. Our responsibility, share knowledge openly, education without borders. Thank you very much.
Thank you very much, Sahan. So, before you do a complex operation, do you look up if there's some video on a platform to look how other people are just doing before you doing your own, as you did it here?
Yes, sometimes I do it from the SAGES in web search, and luckily I have some master surgeons. I went their operations too. But this revisional surgery, I started with my own. And day by day, and I need to see on the videos, and I need to see the OR room maybe alive, but not in the operation. I just see them. It is like that.
Thank you very much. As a last point, but maybe you can stay there for one moment. We have the discussion for another 7 to 8 minutes about should young surgeons still choose a career in the field of metabolic bariatric surgery, considering the ongoing success of obesity management medications. What do you think about that?
Lately, the OAMM is decreasing our surgery numbers, but I believe that that effect is temporary, and I think so. They need to learn it. The bariatric surgery is not just bariatric surgery, and then if something happens for the future, they can go to upper GI surgery or colorectal surgery.
You mean it's a good education for all types of laparoscopic and robotic procedures that you can do in the upper abdomen?
Yeah.
Any other thoughts on that?
So I know we talk about this all the time, and I still encourage our residents to go into bariatric surgery, because I think one of the things that we're starting to recognize in the United States is I think we should call obesity the disease of the decade. There is no more focus on any other disease as highly as obesity is focused on right now. Yes, a lot of it is driven by the pharmaceutical companies, and they're creating more and more drugs that are very good, but we know surgery is still better, and there's a lot of studies, and I know they presented some, if people were at the debates early on, about how in real life scenarios, the majority of patients discontinue their GLP-1s before 1 year. The vast majority of them regain more weight than they lost. In real life, the weight loss is much less than 10% in comparison to what they're seeing in the clinical trials. So they're not actually as good as we think they are right now. And I think we're many years away from them being that good. But in the meantime, there's still a focus for patients on being healthier and being thinner, whereas for a while, especially in the United States, we were normalizing obesity as a normal thing, or this is a healthy way of being, but I think we're kind of changing that stigma and making it more normal is healthy weight now. So I think we actually are going to have a lot of business continuing for a long time. That's my...
Thank you. I'm not a Young IFSO member, but I can give you my 2 cents. Can we agree that 35% of the bariatric patients would at one point require a revision or revisional surgery? So the question is, who's going to perform that kind of surgery? I guess the bariatric surgeon is the one who understands the anatomy and can provide a different strategy. In my career, I've seen a lot of patients treated by non-bariatric surgeons, and the outcome was not exactly the one desired. So to answer the question, yes, we need more bariatric surgeons. Thank you.
And what do you think about endoscopy? This is also something that I think is very interesting, because we did an Young IFSO survey where we saw that about in 40% of the countries worldwide, there is endoscopy not included in the curriculum of bariatric surgery. What do you think? Is it necessary, or can we just leave this completely to the gastroenterologists?
No, endobariatrics is here to stay, and we are responsible to embrace that new approach. So the answer is I would recommend any young bariatric surgeon to also train in endoscopy and advanced endoscopic procedures as well.
Thank you.
I would like to add to this discussion that even if the medications goes well according to the trials and work, we'll have a lot of more severe patients to do surgery in the future. Higher BMIs, weight regains, more complex metabolic diseases, as the safety of the surgery is safer each year. I work in the university hospital. In Brazil, we have public health system, so we have a lot of transplantation patients, Crohn's disease patients, 60, 70 BMI. So this kind of patient will keep coming, and this patient needs a very specialized surgeon because they can't afford a complication. They have a worse, very bad outcome if they're not performed by a bariatric surgeon. So I think this is our future, more severe cases.
Thank you very much. I think this is a good last word. With that, I think we can close the session. And it's a tradition that all the speakers and all the moderators and all Young IFSO members in the room make a photo together. So please come to the front and then we can see that we make a photo. Thank you very much.